This is an evidence-based nursing practice presentation on delayed cord clamping and its effects on preterm infants, presented by Suja Antony. Delayed cord clamping has gained more attention over the past few years for its many benefits to the newborn. Preterm infants appear to benefit most from delayed cord clamping. Delayed cord clamping of more than 30 seconds helps to transfer more blood from placenta to infant, thus increasing blood volume, increasing blood pressure, lesser need for blood transfusion, decreased bleeding, and infection. Until recently and even today, standard care is that the umbilical cord was clamped and cut immediately after the babies are born. Delayed cord clamping is not widely accepted or implemented in the United States. Only few institutions has policy or protocols regarding delayed cord clamping. This may be due to lack of awareness about the benefits of delayed cord clamping or providers' perceptions regarding potential harms associated with delayed cord clamping. For example, it might interfere with resuscitation measures or it may cause postpartum hemorrhage during third stage. Preterm infants are more vulnerable. By providing additional blood by practicing delayed cord clamping, morbidity and mortality and lengthy hospital stay can be reduced. The purpose of this study to look into how delayed cord clamping compared to immediate cord clamping can benefit preterm infants and how this can be successfully introduced and implemented in nursing and medical practice. For this research study, my Picard topic is in preterm births, how does delayed cord clamping compared to immediate cord clamping affect neonatal outcomes? Delayed cord clamping or DCC is considered as more than 30 seconds of clamping and cutting the umbilical cord after birth, and immediate cord clamping is cutting the cord within 10 to 15 seconds after birth. Studies have shown that term babies have higher hematocrits up to 6 months of age due to placental transfusion. This research study explores the benefits and risk of delayed cord clamping in preterm infants. For this study, I used Ida Jane Orlando's nursing process theory as theoretical framework. According to Orlando, when a person is not able to meet the needs that he has, he becomes distressed and is in need of nursing care. Nurse uses standard nursing process which are assessment, diagnosis, planning, implementation, and evaluation, and use this process to produce positive outcomes or improvement in patient condition. Nurse interact with patient by listening, observing, and acting on patient needs and assess and implement according to individual patient needs. In this research study, nurse involves in assessing the newborn needs and implementing the best practice with other healthcare team members to do or assist in delayed umbilical cord clamping in the preterm infants for the optimal neonatal outcomes. For these topics, 6 studies are chosen. 4 studies compared two groups of infants with delayed cord clamping and immediate cord clamping. The given intervention to one group of infants was delayed cord clamping and no intervention, that is immediate cord clamping, to other group of infants. Rabi et al. Conducted a randomized controlled study on 738 infants on timing of umbilical cord clamping. Infants born between 24 to 36 weeks of gestation were chosen for this study, and delay in clamping of the cord were between 30 to 180 seconds after birth. All these infants were held below the level of placenta to maximize the blood flow. DCC was associated with more placental transfusion and reduction in intraverticular hemorrhage, lesser need for blood transfusion, and reduction in necrotizing enterocolitis compared with immediate umbilical cord clamping. One of the study conducted by Mercer J. et al. On very low birth weight infants proves that delayed cord clamping has been associated with higher Bailey psychomotor developmental index scores and less late onset sepsis for very low birth weight male infants at 7 months corrected age. Songdesandre G. et al. Compared the duration of delayed clamping between two groups of preterm infants born before 32 weeks of gestation. In their study, they just increased the duration of delayed cord clamping to one group of infants, that is from 60 to 75 seconds. To other group, they got 30 to 45 seconds of delayed cord clamping. And the longer duration of delayed cord clamping group of infants had higher hematocrits, reduction in delivery room intubation, reduction in hypothermia, and surfactant therapy. They have noticed there is no differences in intraverticular hemorrhage, late onset sepsis, or necrotizing enterocolitis between these two groups. So it clearly shows that just extending the duration of delayed cord clamping from 30 seconds to 60 or 75 seconds in spontaneously breathing infants promotes further placental transfusion in very preterm infants without increasing mortality or morbidity. In December 2012, American College of Obstetricians and Gynecologists published a committee opinion entitled Timing of Umbilical Cord Clamping After Birth. They stated that the single most important clinical benefit for preterm infant is the possibility for a nearly 50% reduction in intraverticular hemorrhage. They also suggested that evidence supports delayed umbilical cord clamping in preterm infants. However, they have some concerns regarding delayed cord clamping. They voiced concerns regarding DCC might interfere in collecting cord blood banking and increase in need for phototherapy due to jaundice. It also might delay the much needed resuscitation in very preterm infants. Some of the recommendations made by ECHO committee were to establish an ideal and optimal time for umbilical cord clamping. And they also said that large clinical trials are needed to see the effects of DCC on infants born before 28 weeks of gestation. Some of the ethical consideration of delayed cord clampings are: some studies suggested that there is increase in serum bilirubin levels and it might cause jaundice and increase in need of phototherapy for preterm infants. Due to extra blood volume, it also causes polycythemia, and this thickened viscosity of the blood can deplete oxygen carrying capacity and increase the risk of respiratory distress. And it also might delay neonatal resuscitation for very preterm infants. Uncertainty about long-term outcomes requires additional adequately powered randomized controlled trials study to establish long-term risk and benefits. There is lack of consensus among clinicians and policymakers on the optimal and ideal timing for the umbilical cord clamping. World Health Organization has recommended 1 to 2 minutes delay in clamping the cord in both term and preterm infants. American College of Obstetricians and Gynecologists did not specify the exact timing, and they are skeptical about WHO's recommendation of 1 to 2 minutes in delaying the clamping of umbilical cord. In ethical terms, the lack of standardized protocols on the clamping time raises a general need for a conceptual clarification on the cord clamping and the related process. Possible grant sources for this research studies are from National Institutes of Health, the Centers for Disease Control and Prevention, that is CDC, and non-profit voluntary health or philanthropic organization, for example, March of Dimes and Burroughs Wellcome Fund. They are some of the institutions who grant funds to conduct research on preterm delivery and preterm infants. Association of Women's Health Obstetric and Neonatal Nurses awards grants to nurses who conduct research on women's health, obstetric, and neonatal nursing. Delaying umbilical cord clamping compared with immediate cord clamping provide additional placental transfusion to the preterm baby and is associated with less need for transfusion, smoother transition of the cardiopulmonary and cerebral circulation, and reducing the need for invasive and potentially injurious resuscitation. Despite the lack of evidence of long-term benefits of DCC in preterm infants, WHO, ACOG, and American Academy of Pediatrics strongly recommends and issued guidelines to practice delayed cord clamping due to the highest level of evidence on short-term benefits and decrease in mortality and morbidity in preterm infants.